palliative care and hospice care both offer comfort and support for patients and their families.
However, there are also differences between palliative and hospice care. We'll talk about the similarities and distinctions on this week's Health Talk.
So stay tuned, we're up next.
Hello, I'm Dr. Eric Mazur.
And I'm Dr. Andrea Peterson. Today we're discussing the differences as well as the similarities between palliative care and hospice care. Our guest is Dr. Heather Sung. She's the clinical leader of the palliative care program at Norwalk Hospital. Welcome to the show.
Good to have you, Heather.
Thank you.
So maybe you can start our viewers off, Heather, by explaining a little bit about what palliative care is.
Yeah. So palliative care is care that is given by a multidisciplinary team that focuses on the individual and what's important to them for quality of life. And it tries to help that individual as they walk through their progressive condition to make choices regarding goals of care to align with what they define as quality of life and relieve symptoms of suffering, whether it be physical, spiritual, or emotional.
And so tell us a little bit then about what makes palliative care somewhat different than hospice care.
That sounds a lot like hospice care, I think, to the average person at home.
That's a great question because it's so important. Oftentimes I'll walk into a patient's room and introduce myself as the palliative care physician, and I see a deer in the headlights look on their face, and they say, I'm not ready for that, and they think that I'm there to, talk to them about dying. And so it's really important to understand the difference. So palliative care embraces all stages of illness from the initial diagnosis, can include curative, and then to the end, and it can include then in the end hospice care.
So there's no limitation to how long palliative care can be applied.
That's right.
And you can treat the patient actively while they're also receiving palliative care. But I think those are both distinctions from hospice, aren't they?
So hospice care typically is for patients who are in their terminal stages. It's benefit provided by insurance and Medicare. Typically, the understanding is that the patient likely has a prognosis of 6 months or less.
A lot of folks may not realize this at home is that Medicare and many of the private insurers have very specific rules around the hospice benefit.
Yes.
And so we sort of, in our minds, equate the two of them.
Yes, yeah. And so a patient may meet the criteria based upon their disease, but they may do well, and they may actually graduate from hospice. But hospice's focus is on symptom management at the last stages of life, as opposed to a curative approach.
Can you do interventional treatments when it is for symptoms? For example, someone with a metastatic cancer to the bone and a sore spot on the bone, will hospice allow you to radiate that under the benefit?
Sometimes radiation is included in it as a comfort, but there are certain restrictions. They will include, for example, having sometimes patients who have a distended belly from their cancer, placing a drain in.
If there's fluid.
To help with symptoms. But it has to be focusing on symptoms. There are financial limitations to certain treatments that can't be covered necessarily under Medicare.
So palliative care is really helping patients and their families through the entire spectrum of advanced or serious illness, and hospice care really is focused on the end of life.
Yes.
And so why did hospice care kind of develop, and tell us what's so wonderful for patients about hospice care? Because I do believe it is a wonderful.
Yeah. Hospice actually started in Connecticut, and
in the United States.
In the United States, yes, that's right. And thank you for clarifying.
I was actually at Yale when the first hospice center was opened in Connecticut back in the 70s, and I remember it well.
Yeah. I think
came from London, didn't it, or from England?
Yeah, yes. I think so.
Modeled
yes.
Mm-hmm.
Yeah. There are so many benefits to hospice, and I think that what I try to tell patients as they confront thoughts of the end of life, where it can be very frightening, it can be isolating, that they don't have to give up hope just because there may not be a curative treatment available to them anymore. And that's what hospice focuses on, is being able to provide hope in other ways. Hope can evolve as your condition evolves. It may
So you're not hoping for a cure, you're hoping to reduce your pain or make the next holiday.
Yes, that's right. Yeah, yeah. Spend time with your loved ones.
And maybe again, for clarifying folks at
Yeah.
home, with these, and a lot of this has to do with insurance, but
Yeah.
with the designation of someone as a hospice participant, there are a lot of benefits they get access to.
That's
Isn't
right.
that true?
Yeah. Yeah, so it's not, there's a medical director or someone who's sort of overseeing your care, but you have nurses, typically, if it's home-based hospice care, providing visits and assessments, sometimes a couple of times a week. It may increase depending upon what your needs are, but that there's someone available 24 hours by phone and or to come emergently if something is happening at home. You've got integrative medicine support, so such things as acupuncture and Reiki, other aspects of care that can provide comfort. You've got spiritual support, and that doesn't have to be of a religious approach, but just sort of addressing the existential, emotional distresses that an individual faces. Social worker support. And then you have bereavement support, which is very important afterwards for the family.
Absolutely, and I think one thing you mentioned and alluded to, one of the things I like to tell patients is hospice is a philosophy, not necessarily a place.
Yeah.
So hospice care can actually be delivered in multiple different settings, can't it?
Yes.
And I think a lot of people think of hospice, I certainly did until I became involved, as a building where you go and get these services, but there are most of the nursing agencies will offer a hospice benefit at home.
Yeah, I actually believe that the statistics show that probably about 40% of hospice care is at home, and then the rest is split between an inpatient setting or a nursing home. Most patients will express a desire to pass away at home, but it's going to depend upon how complex their symptoms are that need to be managed and whether the family can provide that care, because you do require somebody to be present to provide support to that patient.
So as a palliative care provider, are you someone who says to a patient, well, I think you've reached the point where hospice is appropriate?
Yes, that oftentimes may be the conversation that we had, but the wonderful thing is, as the palliative care physician, we hopefully will have had a relationship with that patient earlier on, and then through the course of the disease, so that there's a trust and an understanding and a knowledge of who that person is and what's important to them, and when no longer that treatment is providing them with what they desire in their quality of life.
People, go ahead.
One thing you mentioned earlier on is that hospice may be appropriate for patients whose prognosis from their serious illness is about 6 months or less. And I think that number is important because I think there still is a misunderstanding that hospice is only appropriate when someone is actively dying.
That's right. Yes, that's very important, Andrea, because what we recognize is that hospice is accessed too late. It seems that people only acquire the benefits of hospice, unfortunately, in their last days. But you may be having a terminal condition, but still getting out of the house and going out to dinner or socializing with people, and still be eligible for hospice and the support that it provides. There's been studies done that show the benefits to patients, such as you're probably familiar, Eric, with the TML study that was done on patients with metastatic lung cancer, advanced lung cancer, where those that had hospice earlier on actually did better and lived longer than those who didn't have hospice.
And so much of the focus is on living as fully as possible for as long as someone has.
Yes.
And I think most people think of hospice as equating to cancer patients, but I think we'd like to open that up and get more patients into hospice. Maybe you could give examples of other patients who could benefit from a hospice experience.
So, there are various conditions, heart disease, lung disease, dementia, kidney disease, progressive degenerative neurological diseases,
liver diseases.
Yes,
cirrhosis.
absolutely.
So this would include if someone has a relative with dementia in a nursing home that they're paying for, and then the patient reaches the hospice benefit, they might be able to access that through Medicare.
Yes.
Is that right? So they can go back to a Medicare benefit.
Yes.
Who would they see who would they talk to investigate that?
So there are a lot of palliative care programs now across the country. If they're in the hospital, they might speak with a palliative care physician or team who could determine whether they may be eligible for hospice. Their own physicians also as well can make that determination. With a better understanding of general public and knowing what hospice is, they can initiate that conversation with their physician. Sometimes we as physicians don't think about that and realize. So if you feel that your care is no longer achieving the goals that you want for your quality of life, it's worth a discussion with your doctor.
And I would say from a practical standpoint, as with all things Medicare, it is worth a family would want to know what that benefit actually covers and does not cover. Because like other things in Medicare, it does not necessarily cover everything. That's
so
important
we
to know.
want more patients going into hospice care earlier, but we also want more patients to think about palliative care.
Yes.
So say a few words about that, because that's got a far wider net to help patients.
Yeah.
Doesn't have that specific limitations that hospice does about survival.
I think that what I find most, because I practiced before palliative care, I was a primary care physician and then I was a hospitalist. And I've seen, the change in medicine over, the past 20 years. And I think that what I found hard about doing internal medicine alone was you're strapped for time. You don't have the time to sit with a patient and really talk about other aspects of them as a whole person. And you, as a hospitalist, so a physician who focuses on their care in the hospital
and that
setting.
really, I think, creates a new team approach to healthcare, which I think fills in the missing pieces. And unfortunately, that's all we have time for.
Okay.
Thank you so much.
I want to thank
for
our
all your
guest, Dr.
information,
Heather
though.
Sung,
Thank you.
for joining us today and providing us such important information.
Thank you.
Please remember to send your questions and comments to us at healthtalk@wchn.org. We look forward to hearing from you.
And we look forward to seeing you next week.
Be well.